Hello, this is Jonathan Schwartz at Sanger Heart and Vascular Institute. I will be discussing cerebral protection challenges as part of the structural cases session for Cardiovascular Innovations Digital 2020. Disclosures, nothing to disclose. So, somewhat difficult topic. We will talk about a few different things here. Initially, I considered talking just about difficult cases, but I thought somewhat more interesting is there are a lot of different challenges related to cerebral embolic protection. Some may argue that the biggest challenge may just be the impetus to use it in general for a variety of reasons that we'll discuss. When as part of a case session here, as part of this meeting, challenging anatomy is probably the most obvious thing to discuss, which I will get into a little bit. And then also some common misconceptions, such as the use being time prohibitive, both from the actual individual procedure time when you do it in a single case, and then as well as the learning curve of using the device itself. Cost definitely is an issue. Some people may believe that it's cost prohibitive, but we'll talk about that as well. Trial data do not, at present, support routine use. There is some debate about this, and trials are going to be ongoing soon to investigate this further. And then some may think that newer generation TAVR technology may decrease the stroke risk to the point of not needing to use embolic protection, which we'll also address. So despite innovation and iteration, I would say that stroke rates are still significant. They're both high and constant, particularly related to when compared to some of the other procedures that we do in the cath lab. This is something that we can definitely improve upon. It's also consistent among all different kinds of devices. So this plot displays 30-day stroke rates for the variety of different devices on the market: CoreValve, Accurate Neo, Portico, Sapien, Lotus, Centera. They're all included there, and they all have significant stroke rates that can be improved. This is also independent of the volume that operators do per year and their experience. So even the most experienced operators still have significant stroke rates that can be improved. Some people may think that patients don't have strokes just because it's not apparent. However, most, up to greater than 80% of patients undergoing TAVR do have silent cerebral emboli when it is actually looked for and adjudicated by a neurologist. These silent strokes are actually associated with a decline in cognitive function. So while it may not seem apparent, particularly in the short term that the patients are in the hospital post-procedure, long term it is felt that these somewhat silent or ignored strokes may actually lead to significant cognitive decline later. A big challenge is, are we able to predict the stroke risk of patients? And so far, not very well. Age appears to be the only real predictor in the TVT registry data of stroke in patients undergoing TAVR. And here is just a plot that kind of shows that all of the variety of variables that they looked at here: age, renal function, ejection fraction, access site, none of them seem to be significant. There is a slight trend towards females versus males, but otherwise it's very difficult to predict patients that will suffer stroke in the peri-TAVR period. So what's available in our toolbox to minimize the stroke risk in TAVR? The only FDA-approved device at present is the Sentinel device from Boston Scientific. And here are 4 others that are under investigation. There are a multitude of others. This is just a snapshot of what's available currently, and likely there will be more coming to the market shortly. So another challenge could be, people could ask, well, when should I use it? Should I only use it in patients that I think are high risk because of either comorbidities or their anatomy in particular? This has been examined. Patients with mild aortic valve calcification, moderate and severe, all have significant stroke rates. There is no anatomic subset predictors for stroke benefit with cerebral embolic protection use. So what is our practice here at Sanger Heart and Vascular? We were early adopters of the Sentinel device. We have a pretty systematic approach, which we called Safe and Efficient Routine Use, began in February of 2018. Patients must have right radial access, as that is where the Sentinel device is inserted. Subclavian and arch anatomy is reviewed for every case, and if there is anything in particular that seems to be prohibitive, such as extreme tortuosity or calcification at the ostia of the vessels, then we might either hesitate or deem them non-candidates for Sentinel use. And in general, if deployment is taking a significant amount of time, such as up to 10 minutes, that's about the time when we decide just to keep moving with the procedure. At the bottom of the slide here, you can see 3 representative samples of what was caught in the device post-procedure. As for anatomy review, we do look at the CTA as part of the TAVR CT that is done for every case. If there are greater than 180-degree bends, or if there are serial greater than 90-degree bends, then we take significant pause as to whether we will use the device or not. If there is stenosis or excessive calcific disease, then it is also another reason why we may not use the device. If right radial access is not otherwise needed, then we are able to use the device. If for some reason it is or not available, then we won't use the device. The vessel sizes must be within the range of the device IFU, and we do permit bovine arch anatomy or modest tortuosity. Here's an example of pretty extreme tortuosity. We may even attempt this, but it would be quite difficult to navigate these bends with the device in its current form. Some tips for difficult anatomy if it is encountered: just a slow and steady deployment, be methodical about it, and oftentimes it can be navigated. A stiff coronary wire can help with some tortuosity. Sometimes an IM catheter is useful, particularly for bovine anatomy. It is okay to stop with incomplete deployment if you're only able to cover the brachiocephalic trunk. Then that's just fine. And also then similar techniques to difficult radial access anatomy can be used, such as balloon assisted tracking and things like that. For outcomes and results, personally at our facility, we have had a lower stroke rate, but it was not statistically significant, but it is a very low rate in general. We have not had a single stroke in patients in whom the device was used after a total of 103 patients when the last time that we looked at it. There was a minimal increase in procedure time, only about 2 minutes, and we still are able to get through 5 cases per day, regardless of whether CEP is used or not. This is just demonstrating that in patients prior to embolic protection use, out of 430 patients had about 11 strokes. After we started using it, no patients in which the device was used had any strokes, and device procedure time was only minimally increased. Cost and reimbursement certainly is an issue here. However, this has improved a little bit. CMS did approve the Sentinel device for new technology add-on payment in October of 2018. The device costs about $2,800, and this reimbursement is up to $1,400 if your hospital costs are greater than the DRG. It is thought that in the future reimbursement will eventually be achieved. And then also one thing to consider is what is the incremental cost of TAVR with a patient that does suffer stroke. For a major stroke, it's about $31,000, and a minor stroke is $5,700. This is likely underestimated in contemporary TAVR, as TAVR length of stay has fallen dramatically, but stroke-related length of stay is relatively unchanged, and length of stay definitely contributes to cost. There is a significant morbidity, mortality, and cost in patients that do have stroke. And hospital charges can be $60,000 to $80,000 more when patients do suffer stroke post-procedure. So just a few learning points. Stroke does remain a major concern in TAVR. It does remain unpredictable with regard to risk. Embolic protection use unequivocally reduces peri-procedural stroke risk associated with TAVR by about 60 to 70%. Selective use is not justified. There really aren't any higher risk cohorts that can be identified pre-procedure, and embolic debris is identified in up to 99% of patients if examined. So in conclusion, it is imperative to minimize stroke risk as we expand TAVR into lower risk and healthier younger patients. Silent stroke is still consequential. Even up to 80% of patients will have this, and the long-term implication of embolic events is not fully understood as of yet, but likely will be in the near future. The cost associated with cerebral embolic protection is manageable. Both financial and societal costs of stroke, however, are not. The economics of stroke in the post-TAVR period, primarily driven by an overall financial and societal impacts of stroke-related care in TAVR patients. Thank you so much for your attention.